Good morning, everyone. I'm presenting the topic serotonin syndrome. Moderator is Dr. Neetu ma'am. What is serotonin syndrome? Concurrent administration of an SSRI with a MAO inhibitor, L-tryptophan, or lithium can raise plasma serotonin concentration to toxic levels, producing a constellation of symptoms called serotonin syndrome. Serotonin syndrome is potentially life-threatening syndrome that is precipitated by the use of serotonergic drugs and overactivation of both the peripheral and the central postsynaptic 5-HT1A and most notably 5-HT2A receptors. Conditions that can alter the regulation of serotonin include therapeutic doses, drug interactions, intentional or unintentional overdoses, and overlapping transitions between the medical units. The mechanism associated with serotonin syndrome includes drugs that decrease the serotonin breakdown include monoamine oxidase inhibitors. Drugs that decrease the serotonin reuptake include SSRIs, SNRIs, tricyclic antidepressants, opioids like tramadol, anti-epileptics like carbamazepine, valproate, and antiemetics like ondansetron, metoclopramide. Drugs that increase the serotonin precursors or agonists include tryptophan, lithium, fentanyl, LSD. Drugs that increase the serotonin release include fenfluramine, amphetamines. Drugs that prevent the breakdown of the agent listed above are CYP2D6 and CYP3A4 inhibitors. Example, erythromycin, ciprofloxacin. However, the only drugs that have been reliably confirmed to precipitate serotonin syndrome are MAO inhibitors, SSRIs, SNRIs, and serotonin releasers. How does serotonin syndrome present? It presents as a triad: altered mental states, autonomic symptoms, and neuromuscular excitation. The mental state changes include anxiety, agitation, disorientation. The neuromuscular abnormalities include oculoclonus, muscle rigidity, tremors, hyperreflexia, muscle clonus, bilateral Babinski reflex. The autonomic hyperactivity include hypothermia, dilated pupils, dry mucous membrane, tachycardia, sweating, diarrhea, and vomiting. This serious and possibly fatal syndrome of serotonin overstimulation comprises an order of appearance as the condition worsens: diarrhea, restlessness, extreme agitation, hyperreflexia, and autonomic instability with possible rapid fluctuations in vital signs, myoclonus, seizures, hypothermia, uncontrollable shivering, and rigidity, delirium, coma, status epilepticus, cardiovascular collapse, and death. Diagnosis. The serotonin syndrome is a diagnosis of exclusion. No single diagnostic test can confirm this syndrome. The diagnostic gold standard for serotonin syndrome is diagnosis by a medical toxicologist. In a clinical setting, however, the suspicion of serotonin syndrome and diagnosis must occur rapidly, so treatment can prevent the morbidity and mortality associated with this condition. Therefore, a diagnosis of serotonin syndrome is entirely clinical and is based on the history and physical examination, along with the history of patients' use of serotonergic drug. Several diagnostic criteria have been proposed for serotonin syndrome. The most recent diagnostic criteria is the Hunter serotonin toxicity criteria that have been replaced the older Sternbach criteria in an attempt to simplify the diagnosis. When compared to the gold standard of diagnosis by a medical toxicologist, the HSTC are more sensitive, 84% versus 75%, and more specific, 97% versus 96%, than the Sternbach criteria. Hunter criteria. If the patient is on the serotonergic medication, is there clonus? If it is spontaneous clonus, then it will meet the criteria for serotonin syndrome. If it is inducible or ocular clonus accompanied by either agitation, diaphoresis, or hypertonia plus temperature more than 38 degrees Celsius, it will meet the criteria for serotonin syndrome. If there is no clonus but presence of tremor plus hyperreflexia, then it meets the criteria for serotonin syndrome. Management. Management depends on the symptoms, whether it is mild, moderate, or severe. For mild symptoms, discontinue the offending agents. support via stabilizing vital signs, cooling measures, mild agitation, fever, hypertension, and tachycardia. We give benzodiazepines like diazepam, observed for at least 6 hours. For moderate symptoms like above plus temperature of at least 40 degrees Celsius or hyperactive bowel movements. We follow the management, all the above, plus severe agitation and hypothermia, 5-HT antagonist, cyproheptadine is given, and admission to hospital for cardiac monitoring and observation. For severe symptoms like temperature more than 41.1 degrees Celsius, um, management of all the above, and severe hypertension and tachycardia, esmolol or nitroprusside, sedation and paralysis with non-depolarizing agent and intubation or ventilation, admission to the intensive care unit. Treatment of serotonin syndrome consists of removing the offending agent and promptly instituting comprehensive supportive care with nitroglycerin, cyproheptadine, which is serotonin antagonist, fluoxetine methylsergide, cooling blankets, um, chlorpromazine, dandrolene, benzodiazepines, anticonvulsants, mechanical ventilation, and paralyzing agents. Drug interactions. The SSRIs do not interfere with most other drugs. A serotonin syndrome can develop with concurrent administration of MAO inhibitors, L-tryptophan, lithium, or other antidepressants that inhibit reuptake of serotonin. Fluoxetine, sertraline, and paroxetine can raise plasma concentration of TCAs, which can cause clinical toxicity. Co-administration of paroxetine and tramadol may precipitate serotonin syndrome in elderly persons. This is an example of a patient of a lady precipitating serotonin syndromes. Mrs. J, a 68-year-old retired school teacher in good health, was experiencing anhedonia after the death of her spouse and was started on low-dose SSRI by her psychiatrist. After several weeks, her symptoms began to improve. One morning, while at the local health food store, she inquired if there was any natural products that improved the mood. The store manager informed her that St. John's wort works just like an SSRI. The patient proceeded to take the recommended daily dose of 3 capsules that day, each containing 300 mg of 0.3% hypericin. Later that evening, she began to feel anxious and could not feel asleep. After several hours of doing needlework to pass the time, she began to sweat profusely. She became concerned for her health when she felt her heart racing. She drove herself to the emergency room of the local hospital. On examination, she was observed to be extremely anxious and hyperactive, tachycardic, and mildly hypertensive. She was given a short-acting, fast-onset benzodiazepine. After 4 hours, the patient reported feeling calm and her vital signs had returned to baseline. The emergency room physician informed Mrs. J that although she had taken a single dose of St. John's wort, she had most likely experienced the side effects of an interaction between the plant extract and the SSRI. Known interactions include a maniac reaction and a serotonin syndrome. The patient agreed to discontinue the St. John wards. She was discharged and a follow-up appointment was scheduled with a psychiatrist to discuss treatment options. MAO inhibitors should not be co-administered with serotonergic drugs such as SSRIs, clomipramine, because this combination can trigger a serotonin syndrome. Use of lithium or tryptophan with an irreversible MAO inhibitors may also induce a serotonin syndrome. Tramadol may interact with drugs that inhibit serotonin reuptake. Such combinations can trigger seizures and serotonin syndrome. These events may also develop during tramadol monotherapy, either at routine or excessive doses. Risk of interaction is increased when tramadol is combined with virtually all classes of antidepressants and with drugs that lower the seizure threshold, especially the antidepressant bupropion. These are my references. Thank you. Good morning, everyone. Topic of my presentation is doxepin, and my moderator is Dr. Manparan. Antidepressants. Antidepressants are not recommended as first-line treatment in the recent onset, mild depression, active monitoring, individual-guided self-help, CBT, or exercise are preferred. Antidepressants are recommended for the treatment of moderate to severe depression and for dysthymia. Classification of antidepressants. It includes reversible MAO inhibitors, moclobemide, selective serotonin reuptake inhibitors, fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, escitalopram. Then atypical antidepressants, trazodone, meancerin, metrazapine, bupivacaine, serotonin and noradrenaline reuptake inhibitors, venlafaxine, duloxetine. Then tricyclic antidepressants, um, noradrenaline and 5-HT reuptake inhibitors, imipramine, amitriptyline, trimipramine, doxepin, dothepin. Then predominantly noradrenaline reuptake inhibitors include desipramine, nortriptyline, amoxapine. The mechanism of action of doxepin. It is a tricyclic antidepressant. This image is showing 10 mg capsule of doxepin. It is also available as 25 mg, 50 mg, 75 mg, 100 mg, and 150 mg. Doxepin displays antagonistic property in the central nervous system by blocking the following receptor: histamine H1, alpha-1 adrenergic, and muscarinic. It also inhibits sodium and potassium channel in cardiomyocytes. Doxepin has H1 and H2 receptor blocking action that explains antipruritic effect of doxepin. Pharmacokinetics. Time for peak plasma concentration is 3.5 hours. Plasma protein binding is approximately 80%. Metabolism is hepatic. Active metabolite is desmethyldoxepin. Apparent terminal half-life of doxepin is 15 hours and of desmethyldoxepin is 31 hours. Excretion less than 3% in urine as unchanged drug or N-methyldoxepin. Indications. Doxepin is a tricyclic antidepressant that was FDA approved in 1969 to treat the major depressive disorder. It was primarily approved to treat the disorder, depression. However, it can also target multiple receptors and is beneficial in treating other disorders as anxiety. The oral tablet formulation of doxepin has been FDA approved for the treatment of insomnia also. It is also indicated in skin pruritus. In literature and research studies, it has also proven to be effective analgesic in treating neuropathic pain. It has also been used as prophylactic agent against migraine. Adverse effects. Doxepin blocks alpha-adrenergic receptor and should be monitored carefully in those with cardiovascular disorder because it can cause orthostatic hypotension. Doxepin also blocks muscarinic receptor and produces anticholinergic side effects as dry mouth, constipation, dizziness, lightheadedness, tachycardia, and prolonged QT interval. Contraindications. Antidepressant may cause serious side effects when combined with other medication as different class of antidepressant, opioid, alcohol, herbal medication. An interaction between two different class of antidepressant may lead to excess serotonin in central nervous system. This effect lead to condition known as serotonin syndrome, sometimes described as serotonin toxicity. It may include clonus, fever, diarrhea. This image is showing the serotonin syndrome. It may include clonus, fever, and diarrhea. Serotonin toxicity induces symptoms as mental status changes, neuromuscular excitation. Patient experiences symptoms as confusion, vital sign changes as tachycardia, hypothermia, flushing, tremor, and neuromuscular changes as rigidity, increased reflexes. Another contraindication to prescribing doxepin is in patients with cardiovascular disorder as pre-existing bundle branch blocks. Lastly, it has a poor safety profile in postpartum lactating mothers and is contraindicated in breastfeeding due to its sedative and respiratory depressive effects. Toxicity. Tricyclic antidepressants are one of the most frequently ingested substances used for self-poison in attempt to commit suicide. Overdose of doxepin can affect central nervous system and cardiovascular system. It is also known to block sodium and potassium channel in cardiomyocytes and can reduce cardiac action potential and depolarization and lead to cardiac arrhythmias. It can also lead to neurological effect as coma, grand mal seizures, and respiratory depression. Treatment options that are beneficial in patients with toxicant intoxication include sodium bicarbonate, hemodialysis, or hemoperfusion. These are my references. Thank you.
Good morning, everyone. I am going to present the topic anorexia nervosa and my moderator, Dr. Ashish. The term anorexia nervosa is derived from Greek term for loss of appetite and a Latin one. Anorexia nervosa is a syndrome characterized by three essential criteria. First, self-induced starvation to significant degree of behavior. Second, a morbid fear of fatness, a psychopathology. Third, is the presence of medical sign and symptom of starvation, a physiological symptomatology. Ecology. Biological, social, physiological factors are implicated in the cause of psychological factors are implicated in the cause of anorexia nervosa. Biological factor, endogenous opioid may contribute to the renal hunger in patients. Studies show dramatic weight gain in some patients. Social factors, families of children who present with eating disorder may exhibit a high level of hostility, isolation, and burnout. Psychological factor, it appears to be a reaction to the demand that adolescents behave more independently and increase their social and sexual fulfillment. Clinical features. The onset usually occurs between the age of 10 to 30 years. It is when an individual voluntarily use and maintain the unhealthy degree of weight loss. An individual experience an intense fear of becoming fat. An individual experience significant starvation related medical symptomatology. The behavior and psychopathology are present for at least 3. Diagnostic criteria, restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, and physical health. Intense fear of gaining weight or of becoming fat, or persistent behavior that interfere with weight gain even though at the significantly low weight. Disturbance in the way in which one's body weight or shape is experienced or seriousness of the current low body weight. Coding note, the ICD-9 CM code for anorexia nervosa is 307.1, which is assigned regardless of the subtype. The ICD-10 CM depends on the subtype. These are the subtype restricting type. During the last 3 months, the individual has not engaged in the current episode of binge eating. Binge eating. Binge eating during the last 3 months, the individual has not engaged in the recurrent episode of binge eating, self-induced vomiting. Lab examination. Complete blood count reveals leukopenia with relative lymphocytosis, hypokalemic acidosis. Lab examination. Complete blood count reveals leukopenia with relative lymphocytosis, hypokalemic alkalosis, fasting serum glucose often low, slightly serum slightly amyloid levels elevated. ECG may show ST segment and TBO change. treatment. The first consideration in the treatment of anorexia nervosa is to restore patient nutritional state, dehydration, starvation, and electrolyte imbalance. Psychotherapy, cognitive behavioral therapy, dynamic psychotherapy, and pharmacotherapy, gabapentin, amitriptyline, clomipramine, and fluoxetine. The references.
Histamine have a precursor histidine, and it is formed from histidine, and then it is packaged to synaptic vesicles. So mainly there are four histamine receptors: H1, H3, H1 receptor by default has a role in wakefulness. H1 receptor, when it is there is no H1 antagonist, it plays a role in normal wakefulness, alertness, and the normal cognitive actions. So when an H1 receptor antagonist is given, most negatively it causes sedation. May predominant H1 receptor is present everywhere. Predominantly, it has actually wakefulness. There are also present other functions like gastric juice, etc. But the predominant is wakefulness. H2 receptor is mainly present in the gastric mucosa. The major function of the H2 receptor is acid secretion. So very common antacid we use ranitidine, H2 receptor. So H1 receptor, when it is not integrated, acid secretion is there, and H2 receptor antagonist ranitidine causes increased acid secretion. But both of these also have some CNS side effects. The H3 receptor is mainly present in the CNS, and the H4 receptor plays the role in allergies. H4 receptor antagonists giving allergies to prevent the allergic reactions. The histamine is also associated with the change in the shape and size of the cytokine that leads to the symptoms of allergic reactions that we see, the vasodilation, the rashes, the itching that we get. So some anti-allergic effect is present in all histamine blockers, but H3 and H4 receptor blockers have the biggest anti-histamine effect.
Thank you, ma'am. Now we go to the committee. We'll be talking about
Good afternoon, everyone. I'll be talking about norepinephrine and epinephrine. So, as we all know, norepinephrine and epinephrine, these are also known as the these neuro basically these are the stress neurotransmitters. So, epinephrine is basically restricted to the peripheral nervous system, and norepinephrine is one of the major neurotransmitters in the central nervous system. Norepinephrine basically stands for normal epinephrine. And now norepinephrine neurons, the cell bodies of these norepinephrine neurons, they are located in the locus coeruleus in the brainstem. And from there in the brainstem, from the locus coeruleus, all the projections are to the forebrain, thalamus, cerebellum, and to the spinal cord. Now, this locus coeruleus basically this has different activity modes. So tonic firing with short, it has tonic firing with short periods of burst firing. So the phasic mode is basically in response to novel stimuli, arising stimuli, the fight and flight, and there is like decreased firing during states of sleep or when eating. So it has this phasic response. Now, epinephrine, the few neurons of epinephrine are located in the caudal pons and medulla, intermingled with the noradrenergic neurons. Now, let us talk about the synthesis of norepinephrine and epinephrine. So, it is basically synthesized from the tyrosine. Tyrosine is then converted into dopa by the enzyme tyrosine 3 monooxygenase, then dopa into dopamine. Dopamine is then converted into norepinephrine, and then norepinephrine is converted into finally into epinephrine. Metabolism of this is by the MAO-A enzyme, and we know the MAO-A inhibitors are also implicated in the as drugs of as antidepressant drugs. So like norepinephrine is also said to be associated with mood disorders. See, so we all know that the classical theory of depression is that there is a depletion in the amount of monoamines. So it is also so like norepinephrine being one of the major neuroamines along with serotonin and dopamine. So these are deficient as per the classical theory of depression, and which is one of the theories which would lead to depression. Now, the receptors for these neurotransmitters, we all know that we have alpha for adrenergic receptors. We have alpha receptors and we have beta receptors. Alpha receptors is alpha 1, alpha 1A, 1B, and 1D, and then alpha 2A, 2A, 2B, 2C, 2D. Then beta 1, we know beta receptors, there are three types: beta 1, beta 2, and beta 3. Beta 3 is in adipose tissue, beta 1 is in the heart and kidney, and beta 2 is in all the other smooth muscles. Norepinephrine is also implicated in the sleep-wake cycle. Noradrenergic cells from the locus coeruleus, they project this directly through the forebrain and cerebral cortex and show their highest discharge rates during wakefulness. These cells decrease their firing during non-REM sleep and cease firing altogether during the REM sleep. This neurotransmitter is also implicated in the fight or flight response, as we all know that whenever we are in such a situation of stress, so there is increased arterial pressure, there is increased blood flow to the active muscles concurrent with decreased blood flow to the other organs like GI tract and kidney, which are not needed for the rapid motor activity. Increased rates of cellular, it also causes increased rates of cellular metabolism throughout the body, increased blood glucose concentration, increased glycolysis in the liver, increased muscle strength, increased mental activity. Then the drugs acting on the adrenergic system include the tricyclic antidepressants such as the desipramine. These are inhibitors of NET, norepinephrine transporter, and serotonin transporter. Then, as I mentioned about MAO-A inhibitors, alpha 1 receptors is also they are also inhibited by prazosin, which is used as an antihypertensive drug. Then alpha 2 agonists such as clonidine, we often use for sympatholysis. Then beta adrenergic antagonists like propranolol also we use in various anxieties.
Thank you now. Just with three consistent at the bottom, we talk about acetyl.
Acetylcholine is a neurotransmitter involved in various physiological processes like muscle contraction, coordination, memory, and autonomic nervous system regulation. So there are only two types of acetyl. One is nicotinic acetylcholine receptor, which is a ligand-gated ion channel which is present in central nervous system, peripheral nervous system, and at the neuromuscular junctions. It is named nicotinic because they can be activated, which is found in a which is an alkaloid found in tobacco. It allows flow of ions across the cell membrane in response to acetylcholine binding, leading to depolarization and excitation of the post-synaptic cell. Nicotinic receptors play a very important role in various functions, including muscle contraction, modulation of neurotransmitter release, cognitive functions, as well. Another acetylcholine receptor is muscarinic receptor, which is a G protein coupled receptor. It is found in central nervous system, peripheral nervous system, and various other organs, including heart, lungs, and GI tract. It is named muscarinic because they can be activated by muscarine, which is an alkaloid found in mushroom. Activation of muscarinic receptors lead to modulation of intracellular signaling pathways through G protein mediated mechanism, resulting in diverse physiological effects. It is involved in regulating heart rate, smooth muscle contraction, glandular secretion, and various other aspects of cognitive function. So the mechanism of action of acetylcholine is that acetylcholine is synthesized in the nerve terminal by enzyme polyacetyl transferase, that is CHAP, which combines acetyl coenzyme A with choline once synthesized. Acetylcholine is stored in synaptic vesicles, which is located at the nerve terminal. Upon releasing an action potential, calcium ion influx is there at the nerve terminals, causing synaptic vesicles to fuse with the presynaptic membrane and release acetylcholine into the synaptic level. Then the acetylcholine diffuses across the synaptic cleft and binds to the specific receptors of the postsynaptic membranes. When acetylcholine binds to the nicotinic receptor, it leads to the depolarization of the postsynaptic membrane. And when acetylcholine binds to muscarinic receptor, it leads to its action. So the main actions of acetylcholine is at the neuromuscular junction, it causes muscular contraction by binding to a nicotinic receptor of the skeletal muscle cells. In the autonomic nervous system, it acts as a neurotransmitter in both sympathetic as well as parasympathetic divisions of autonomic nervous system. And the autonomic division, acetylcholine is the primary neurotransmitter which is released, which acts on the muscarinic receptors to cause decrease in heart rate, increase GI motility, and stimulation of glandular secretion. At the central nervous system, it plays a very important role in cognition, memory, and arousal. And its peripheral functions are which it leads to regulation of heart rate by modulating cardiac conduction and contractility, as well as stimulating secretions of the exocrine glands. Psychiatric relevance of acetylcholine is that it has a very important role in cognitive functions like memory, learning, attention, and executive function. So, attention with projection from basal forebrain to the cerebral cortex. So, it plays a major role in attention deficit hyperactivity disorder. So the drugs which are implicated which directly target the acetylcholine system are acetylcholine esterase inhibitors like donepezil, ribostigmine, galantamine, which is used in Alzheimer's disease. It inhibits the acetylcholine esterase enzyme, which leads to the increase in the acetylcholine concentration in synaptic cleft, and which leads to the cholinergic enhancing of the cholinergic transmission. Other drugs are pilocarpine, bethacholine. Pilocarpine is a muscarinic receptor agonist, which directly mimics the action of acetylcholine at the muscarinic receptors, and bethacholine, which is used in urinary retention. Other drugs are nicotine receptor agonists, which mimics the acetylcholine activity at the nicotinic receptors and can be used in nicotine replacement therapy in the smoking cessation. Other drugs are anticholinergic drugs, which inhibit acetylcholine by competitively inhibiting its binding to muscarinic receptors like oxybutynine, which can be used in overactive bladder, scopolamine, which can be used in motion sickness, and benztropine, which can be used in Parkinson's disease. The final drug is cholinergic antagonist, which inhibit acetylcholine by inhibiting nicotinic receptors. Example are vecuronium and pentyronium epinephrine. It is used as an anesthetic agent for muscle relaxation and also used in treatment of neuromuscular disorders like myasthenia gravis.
Thank you, Mark. Very good afternoon, everyone. So like most of the topic has already been covered, so I'll just go through what has been left. So basically, amines are one of the most important classes of organic compound which can be derived from when we replace one or more hydrogen atom of ammonia molecule with another alkyl group. So basically, we talk about the neurotransmitters in amine group are dopamine, histamine, serotonin, epinephrine, and norepinephrine. So in the last class, Dr. Nitu already talked about dopamine and serotonin. So we are going to talk about the other three. So first we'll talk about histamine. So if we talk about the anatomy of the histamine, it is The histamine is secreted from the tuberomammary complex of the posterior hypothalamus, from the mast cell, and from the enterochromaffin-like cells. And this function is there in regulation of sleep and arousal, feeding and appetite, allergic reactions, and acid secretion in the stomach. So synthesis already explained by ma'am. So we'll go to the receptors part. So there are basically four receptors. So H1, H2 are post-synaptic receptors. And H3 receptor is a pre-synaptic receptor. So H3 is an autoreceptor. So autoreceptor is a receptor which act as a brake. So whenever it is stimulated, it will decrease the further release of histamine. And there's also a proposed thesis that at the synaptic cleft, there is some amount of histamine. It diverges from there, and it also goes to the NMDA receptors, and they also affect the NMDA receptors also, thus altering the glutamate secretions. So H1 receptor already it has been talked by ma'am. So when histamine itself, sometimes the histamine itself acts as an H1 receptor, and it thus give a secondary messenger for the activation of phosphatidyl inositol and the transcription factors. So the H1 receptor is responsible for awake procognitive alerts. So H2 receptors already talked. It helps in the secretion, like when we give H2 receptor antagonist and like ranitidine, it decreases secretion of acid in the stomach. So H3 receptor is the autoreceptor we are talking about. And H4 receptors, they are the receptors. They are less likely to be found in the CNS, and they have been detected in the GI tract, dermal fibroblast, CNS, and primary sensory effect neurons. So if you talk about the wake circuit histamine, so basically the tuberomammary nucleus, it has its it has its projections in the brain, like it gives a projection in the prefrontal cortex, in the thalamus, in the basal forebrain, and in the brainstem also. So arousal spectrum of the sleep. So we talk about this diagram. So basically what it says that for arousal, like for a arousal and it has to be maintained in an equilibrium. So when not only histamine but other neurotransmitters like serotonin, acetylcholine, norepinephrine, they has to be maintained in an equilibrium for a proper arousal and a proper wakefulness. So whenever there is a decrease in these neurotransmitters, there is deficient arousal, or there is a cognitive dysfunction, and there is excessive daytime sleepiness. Wherever when there is increase in these neurotransmitters, there is excessive arousal, we can say, like pain, fear, hallucination, and psychosis. Cognitive dysfunction is there, whereas overstimulation of the cognitive functions are there. So basically says that we have to maintain this arousal has to be maintained at an equilibrium point with respect to all the neurotransmitters present. So if we talk about the relevance in psychiatry, it has relevance in the mood disorders, schizophrenia, insomnia, and hypersomnia. So now we'll talk about the non-epinephrine. Epinephrine has already been explained very nicely by Asthaman. So the synthesis and the termination part has already been discussed. The epinephrine helps in the flight and fight response of the body. So if we talk about the non-epinephrine, only the alpha-2 receptor here is the autoreceptor, which it is a pre-synaptic receptor, which decreases the secretion of non-epinephrine. So non-epinephrine, it also has a very important role in it. Has a, like I said, not only histamine, but there's all the neurotransmitters when they work in an equilibrium, it helps in the maintaining a normal sleep-wake cycle. So non-aggregating cells from the so non-aggregating cells from locus coeruleus project directly throughout the brain, forebrain, and cerebral cortex, and show highest discharge rates during the wakefulness. So this when the discharge rate are seen at their maximum when the patient when we are awake, but when we are going into an NREM sleep, so this rate started decreasing. And when there is REM sleep, there is no firing of this noradrenergic cells. And like the ma'am already told about the classic theory of decrease of the neurotransmitters. So talk about acetylcholine. Acetylcholine, there are two clusters of cholinergic projection neurons. First in the basal forebrain complex, and the second in the mesopontine complex. So the basal forebrain complex neurons located in the medial central nucleus, the diagonal band, and the nucleus basis of a Maynard provide most of the cholinergic innervation to the telencephalon. Whereas the mesopontine cholinergic neurons, they supply the thalamus. And the cholinergic interneurons is the principal source of striatal acetylcholine also. So synthesis has already been discussed. The muscarinic receptors has been discussed. So we'll talk about the Alzheimer's disease. So in Alzheimer's disease, it is seen that there's degeneration of the neurons in the nucleus basalis. So basically, there's decrease in the acetylcholine of the body. So the severity of the disease depends on the amount of acetylcholine that has been decreased. So what we see here that there's the projections, this projection from the basal forebrain to the hippocampus and the mesocortex, there is acetylcholine projection. So as the when they starting prodrome of the Alzheimer's disease, so what will happen? There is decrease in the acetylcholine. So what we can do that we give acetylcholine esterase inhibitor. So what will they will do that they will increase the acetylcholine in the hippocampus and the neocortex of the brain, and thus we can it can help in proper functioning of the memory. So these are my references. Some other pathway actually how will it